A user named Capri-san asked a great follow-up question on yesterday's video. How do the major bacteria change depending on the anatomic location and the species we're talking about? So that will be the topic of today's video. Instead of memorizing, this drug goes with this disease. Think in 3 steps. Where is the infection? What bacteria usually live or invade there? And what drug class actually reaches that tissue and targets that organism? Let's start with the respiratory system. For cattle, the big respiratory memory phrase is, mooing pastures have Mycoplasma. The capital letters stand for Mannheimia hemolytica, Pasteurella multicida, Histophilus somni, and Mycoplasma bovis. These are the classic bacterial players in bovine respiratory disease. Mannheimia is the one I especially associate with severe fibrinous pneumonia and leukotoxin-mediated damage. Pasteurella is a common opportunist. Histophilus can cause respiratory disease but can also act more systemically. Mycoplasma bovis is important because it has no cell wall, so beta-lactams like penicillins and cephalosporins are not a great choice if mycoplasma is the main concern. So in cattle respiratory disease, I think about labeled cattle drugs like telithromycin, gamithromycin, tildapiricin, tilmicocin, florfenicol, ceftiofur, oxytetracycline, or enrofloxacin, depending on the case, the label, the class, and withdrawal rules. A macrolide, like telithromycin, makes sense when I want strong respiratory distribution and coverage for common bovine respiratory pathogens, including mycoplasma activity depending on susceptibility. Florfenicol is another strong respiratory option because it has broad respiratory use and is a different class from macrolides. Ceftiofur, a third-generation cephalosporin, can be useful for many bacterial respiratory cases, but I would remember that ceftiofur is not my mycoplasma drug. If there is poor response or resistance is suspected, I do not just keep repeating the same drug class. I would culture when possible and switch based on susceptibility. For example, if a calf does not respond to a macrolide, the next logical class might be florfenicol or ceftiofur, depending on the case. A labeled fluoroquinolone, like enrofloxacin, may be an option in some cattle respiratory cases, but food animal laws matter, and extra-label fluoroquinolone use in food animals is prohibited in the United States. For a small animal respiratory disease, I use the phrase, barking dogs meet strep. That stands for Bordetella bronchoseptica, Mycoplasma species, and Streptococcus zooepidemicus. In cats, I change the phrase to, cats cough Mycoplasma and chlamydia. That reminds me of Mycoplasma felis and Chlamydia felis, which are important bacterial or atypical agents in feline respiratory disease, even though viruses are often involved too. This is why doxycycline, a tetracycline, is often a logical first antimicrobial for many canine and feline upper respiratory infections when bacteria are suspected. Doxycycline is useful because it reaches respiratory tissues and covers atypical organisms like Mycoplasma and chlamydia, which beta-lactams do not cover well. In cats, I remember not to dry pill doxycycline because esophageal irritation and strictures can happen. If the case looks like true bacterial pneumonia instead of mild upper respiratory disease, then I think broader. I would consider thoracic imaging, culture if possible, and drugs like ampicillin sulbactam or amoxicillin clavulinate for common secondary bacteria. If resistance is present or the patient is very sick, I may need to escalate based on culture to a fluoroquinolone like marbofloxacin, pradofloxacin, or enrofloxacin, but I would be cautious with enrofloxacin in cats because of retinal toxicity risk. For horses, the respiratory phrase is stable streps, foals rhodo. That reminds me that adult horses often make me think about Streptococcus equis subsp equi and Streptococcus equis subsp zooepidemicus, while foals make me think about Rhodococcus equi. Strep organisms are generally beta-lactam friendly, so penicillin-type drugs can make sense when treatment is indicated. But Rhodococcus equi is different. It is intracellular, causes abscessing pneumonia in foals, and is classically treated with a macrolide plus rifampin, such as azithromycin plus rifampin or clarithromycin plus rifampin. The caution is that macrolides are not casual horse drugs. Adult horses can develop severe antimicrobial-associated colitis, so if a foal is being treated with a macrolide, I also think about preventing exposure to the mare. Rifampin should not be used alone because resistance can develop quickly. If a foal is not responding, the next step is not random substitution. The next step is culture, susceptibility, ultrasound follow-up, and a careful treatment plan. Now let's move to skin and wounds. For dog and cat skin, the phrase is, skin staph starts scratches. The big organism here is Staphylococcus pseudintermedius, especially in dogs. Skin infections often happen because the skin barrier is damaged, the animal has allergies, the patient is licking or scratching, or normal skin bacteria get into the wrong place. For superficial pyoderma, I do not want to jump straight to the strongest drug. If topical therapy is enough, I think about chlorhexidine-type topical treatment first. If systemic antibiotics are actually needed, common first choices include cephalexin or cefadroxil, which are first-generation cephalosporins. Amoxicillin clavulanate is another reasonable choice in many skin and soft tissue cases, and clindamycin, a lincosamide, can be useful when the organism is susceptible, especially when gram-positive and anaerobic coverage is helpful. If the infection is recurrent, deep, rod-shaped on cytology, or not responding, culture becomes much more important. Methicillin-resistant Staphylococcus pseudintermedius changes the game. At that point, I do not simply choose a bigger drug blindly. I use culture and susceptibility, intensified topical therapy, and only consider drugs like doxycycline, chloramphenicol, trimethoprim sulfa, rifampin combinations, or fluoroquinolones if the susceptibility report and patient safety support it. Rifampin should not be used alone, and fluoroquinolones should not be used just because they sound strong. For bite wounds and abscesses, use the phrase, bites paste deep anaerobes. That means Pasteurella is common in dog and cat bite wounds, and deeper bite wounds often include anaerobes. For the most common anaerobes, I would keep it simple and remember Bacteroides, Fusobacterium, and Clostridium. Bacteroides is a classic anaerobe for deep, dirty, mixed infections, especially wounds or infections connected to the mouth or gastrointestinal tract. Fusobacterium is important in necrotic tissue, oral disease, abscesses, and ruminant foot or liver abscess problems. Clostridium matters because it is a spore-forming anaerobe and can produce toxins, so it shows up in severe wound infections, myonecrosis, blackleg-type disease, tetanus-type disease, and some enteric diseases. For dog and cat bite wounds, amoxicillin clavulanate is a very logical first choice because it covers Pasteurella, many gram-positive organisms, and many anaerobes. The clavulanate helps when beta-lactamase-producing bacteria are present. But bite wounds are not only antibiotic problems. They are also drainage, lavage, debridement, and source control problems. If a bite wound is abscessed or failing therapy, the next choice is not just stronger antibiotic. The next step is drainage, culture, and adjustment based on what grows. Now let's talk about the urinary tract. For urinary bacteria, the phrase is urine peaks. Proteus, Enterococcus, E. coli, Klebsiella, staph. That gives you E. coli, Proteus, Klebsiella, Staphylococcus, and Enterococcus. E. coli is the big one in dogs and cats. Proteus and Klebsiella are gram-negative rods. Staph can occur, especially from skin or ascending infection. Enterococcus is important because it can be resistant and because cephalosporins are not reliable Enterococcus drugs. For a simple dog cystitis case, I usually think first about amoxicillin or trimethoprim sulfa, because those are narrower, urine-focused choices when the patient is stable and uncomplicated. If beta-lactamase-producing organisms are suspected or culture supports it, amoxicillin clavulanate may make sense. If the case is recurrent, complicated, male, associated with pyelonephritis, associated with prostatitis, or not responding, I want culture and susceptibility. If resistance is present, the next choice depends on the organism. For resistant gram-negative rods, drugs like marbofloxacin, enrofloxacin, pratofloxacin, cefpodoxime, or amikacin may become options depending on the culture, infection site, kidney values, and patient safety. Fluoroquinolones are especially tempting for gram-negative urinary infections and prostatitis because of tissue penetration, but they should be reserved, not reflexive. A key urinary nuance is Enterococcus. If the culture grows Enterococcus, I do not assume cephalexin or cefpodoxime will work. I think amoxicillin or ampicillin if susceptible. If Enterococcus is resistant, I follow susceptibility carefully instead of guessing. For Pseudomonas, I also think culture-guided therapy. Possible options may include a fluoroquinolone or an aminoglycoside like amikacin, but renal safety matters. Now let's touch anaerobes and gut-adjacent infections. The phrase is, anaerobes hide deep. This means anaerobes like low oxygen spaces, dental disease, deep abscesses, devitalized tissue, bite wounds, pleural space infections, peritonitis, and necrotic wounds. The main anaerobes I would keep in your head are Bacteroides, Fusobacterium, and Clostridium. A simple memory phrase is, deep bites form clots. Bites reminds you of Bacteroides. Form reminds you of Fusobacterium. Clots reminds you of Clostridium. For dogs and cats, clindamycin is useful for many gram-positive and anaerobic oral infections, especially dental disease and some abscesses. Amoxicillin clavulinate is often a better broad bite wound choice because it covers Pasteurella and many anaerobes together. Metronidazole, a nitroimidazole, is mainly an anaerobe and protozoal drug, but it is not a general diarrhea drug for every soft stool. Species matters here. I am cautious with clindamycin in horses, rabbits, rodents, and ruminants because disruption of normal gut flora can be dangerous. In food-producing animals, metronidazole is prohibited from extra-label use in the United States, so legality matters as much as drug spectrum. For pigs, the respiratory phrase is, pigs breathe MAPS. That means Mycoplasma hypneumoniae, Actinobacillus pleuropneumonia, Pasteurella multicida, and Streptococcus suis. Mycoplasma again reminds me that there is no cell wall, so beta-lactams are not the main answer for Mycoplasma itself. Tetracyclines and macrolides are often considered for Mycoplasma-type respiratory problems depending on label and herd protocol. For Actinobacillus, Pasteurella, and Streptococcus, choices may include ceftiofur, fluorphenicol, penicillin or ampicillin-type drugs, tetracyclines, or macrolides, depending on the suspected organism and regulations. If resistance or poor response is present, herd-level culture and susceptibility matter because treating individual pigs without fixing ventilation, stocking density, co-infections, or vaccination programs will fail. For poultry, use the phrase, birds cough Mycoplasma and E. coli. That keeps Mycoplasma gallisepticum, Mycoplasma synoviae, and E. coli in your head. Mycoplasma in poultry, like Mycoplasma in other species, lacks a cell wall, so penicillins are not the right mental category. Tylosin, a macrolide, and tetracyclines are classic drug categories used for Mycoplasma control where legal and appropriate. If E. coli or sacculitis or colobacillosis is suspected, culture and susceptibility are very important because resistance can be a major issue. Poultry medicine is flock medicine, so biosecurity, testing, vaccination strategy, ventilation, and withdrawal rules are just as important as the drug. So the practical way to remember all of this is not to memorize one antibiotic per disease. Instead, connect the organism to the body system, and then connect the organism to the drug class. If the bug has a cell wall, beta-lactams may be useful. If the bug is Mycoplasma or intracellular, think tetracyclines or macrolides instead. If the infection is deep, oral, abscessed, necrotic, or anaerobic, think about amoxicillin clavulinate, clindamycin, or metronidazole, depending on species and legality. If the infection is urinary, think about urine concentration, prostate involvement, kidney involvement, and culture. If the infection is food-animal related, think about labels, withdrawal times, and prohibited extralabel use before anything else. And when resistance is present, the next choice should not be a guess. The next choice is culture, susceptibility, source control, and switching to a different class only when the organism, tissue, patient, and law all support it.